Hello and welcome to today's live chat about sleep. Thank you for joining us. My name is Ed Bottomley with the Michigan Medicine Department of Communication, and I'm going to be your host for today's chat. And today we're joined by Dr. Cathy Goldstein and Dr. Deirdre Conroy from the Michigan Medicine Sleep Disorders Centers. We'll move on to our questions for our panelists in a moment, but first a few housekeeping items. You can submit questions at any time for our panelists to answer during today's chat. Questions can be submitted by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can send a private message to us via Facebook or email us at ask-mishmed@med.umich.edu. One more time, that's ask-mishmed@med.umich.edu. If you can't stay for the whole chat, or you want to share the recording with a friend, a video of this chat in its entirety will be available on our Michigan Medicine Facebook page, our Michigan Medicine Twitter account, and it will also be posted to our YouTube account as well. Now, let's let our experts introduce themselves. First up, welcome Dr. Conroy.
Hello, thank you for having me today. I'm so excited to talk about sleep with all of you. My name is Deirdre Conroy. I'm a clinical psychologist. I am the clinical director of the Behavioral Sleep Medicine Clinic in the Department of Psychiatry at Michigan Medicine. And while I addressed all sleep disorders, I specialize in insomnia therapy. And so I'm happy to chat with all of you. Thank you.
Fantastic. Happy to have you with us, and welcome Dr. Goldstein.
Hi, everybody, and happy Sleep Awareness Month. Thank you for having me. I'm a neurologist at the University of Michigan Sleep Disorders Center, where I see patients with all sorts of sleep disorders, from obstructive sleep apnea to circadian rhythm sleep-wake disorders.
Fantastic. Well, it's very nice to have you both here. And let's jump right into today's topic of sleep. And first, let's talk about the basics of sleep and how to get a good night's rest, even during stressful times. Dr. Goldstein, why is sleep important?
Well, sleep is important for a multitude of reasons. We used to think of sleep as just being this recovery period, but people have really looked into why we need sleep, because it takes up, a third of our day. It's a vulnerable time when you think about when we were in less protected circumstances, but a lot happens during sleep. So regeneration, healing, and what we know most about is the effects on memory. So memory consolidation occurs during sleep, and also new evidence shows that we need sleep to remove the harmful byproducts of metabolism that go on during the day, because the central nervous system doesn't have what we would typically think of as a lymphatic system. So these are some of the kind of leading hypotheses as why we need sleep. And the things we know the most about is what happens when you don't get enough sleep. So if you don't get enough sleep, you have decreased alertness. What does that mean? That means you can't attend to things. If you're driving a car, your reaction times might be impaired. You may go off the road. That's the more obvious manifestation of not getting enough sleep, but there's some more as well. So short-term effects on cognition, like I just discussed, also long-term effects on thinking and memory down the road, and potentially even increased risk of dementia. We also know that not getting enough sleep increases your risk of heart disease, high blood pressure, obesity, diabetes. And what we're thinking about a lot now is infection because of the COVID pandemic. And we know that individuals that are sleeping less than 5 to 6 hours per night are much more likely to be infected with a virus, not necessarily COVID, but other viruses that have been studied if they're exposed. And I'm hopeful too that people are starting to get their vaccine appointments, and that's another part of infection and immunity that we know sleep is required for. So sleep before and after getting a vaccine is required for a good, robust, appropriate immune response. Mood is another one. People are obviously irritable when they don't get enough sleep, but there's much more problematic mood disorders in context of chronic partial sleep deprivation, which we know is a problem for at least 30% of our population.
Thank you. That's a fantastic overview, and it leads quite nicely into our next question. Is it normal that I've been having a hard time sleeping lately with the pandemic and all the other stressful things happening in my life? And what about my intense dreams?
Sure. So the pandemic has really been this interesting observation because we've had this, this is a pandemic that's occurring in 2020, 2021, and, not hundreds of years ago. So the reason that's interesting is because although you can imagine that the primary thing we see is that many people are experiencing a great deal of psychological stress, resulting in insomnia and also nightmares because of that emotional processing that takes place during sleep and sometimes plays out in our dreams. But one of the most interesting things is because people are learning and working remotely, we've had a lot of patients that have actually had improvement in their sleep. And that's because they, firstly, have more time to sleep. And two, we often kind of in the usual world, we have to get up a bit too early than our internal timing system would like to commute and get to work and get children to school. And so now that we can go to bed later, wake up slightly later and sleep longer, there's many people who report they're sleeping better and feeling more alert during the day. However, if that's not you and you're somebody that has experienced insomnia during the pandemic, that has been very, very common. And that's obviously a response to the psychological stress associated with the uncertainties, both related to people becoming ill, yourself, family members. All of these things have been cited as items that are associated with increased sleep disturbances during the pandemic, but also financial and concerns just related to all this uncertainty in general. And our use of electronic devices near bedtime has probably increased quite a bit, and that's caused some problems with sleep as well. And Dr. Conroy and I actually did a study together about this, and she can tell you some of the details about that.
Oh, yes, please.
Yes, thank you, Dr. Goldstein. I was also going to just comment on, the effect on mental health and also occupation or job role. So in our study, we found that regardless of your occupation, mood declined during the pandemic. And when we looked at sleep and how sleep was affected, we found that sleep worsened in those who were frontline workers. Often people are working rotating shifts or working night shifts. And that finding has actually been shown globally. So people who are, again, frontline workers are exposed to many more stressors, and that can affect the anxiety there, can affect sleep. So we saw actually a reduction in total sleep time in those people who are first line responders.
Yeah, that's absolutely fascinating. Thank you. Thank you both for your answers on that. The next question we have, I'm going to push to you first, Dr. Conroy. What should you do if you can't fall asleep?
So when we can't fall asleep, I would like to say first that we're not light switches. We'd like to be. I think that most of the people that I talk to say, well, why can't I just shut it off immediately and fall right to sleep? But they say my mind is racing, my mind is spinning. And so one of the factors that can play a role is level of alertness before bedtime. So I emphasize a time period. You can call it a buffer zone, a wind down period, but it is just an allocated time, whether it's 30 minutes or 60 minutes, that you dedicate to shutting down. We all have to shut down our computers, and it takes a second for all the files to go away. So you give yourself a period of time where you are engaging in certain activities that are pleasant, don't require a lot of mental stimulation, don't respond to emails or difficult conversations, dim the lights. So we will talk a little bit more about that and how light exposure affects the sleep process. You want to avoid certain foods or excess stimulants. And so I would like it to be a real quiet time for the brain and the body to prepare for sleep to unfold.
Thank you. I see you nodding there, Dr. Goldstein. Do you have anything to add?
I totally agree with that shutdown process. And now more than ever, where our work and our home environment have become one and the same, this is even more important to separate these in both time. So like Dr. Conroy said, you can't go immediately from work mode to sleep mode, and also location. So if you can ideally move your home office, your remote office out of the bedroom, or your remote learning environment out of the bedroom, that separation really helps you associate the bed and the bedroom with sleep.
Thank you. Thank you both for that. The next question, let's push this to Dr. Conroy first. What about if you wake up in the middle of the night and you can't fall back asleep?
So waking up at night is actually one of the more common types of insomnia. So insomnia can be characterized by difficulty falling asleep, difficulty staying asleep, waking up too early, having next day dysfunction. Waking up during the night is very common. In fact, for many of the listeners or watchers out there, they might say, I wake up at 3 a.m. like clockwork all the time and I can't get back to sleep. There is a process that many may have heard already. I encourage people to first kind of rely on some deep breathing, I would encourage everyone to learn how to deep belly breathe give it 20 to 30 minutes while lying there. If you are unable to return to sleep, I recommend that you get out of the bed and go into another environment. Now, if you can't leave the bedroom, maybe there's a chair next to your bed, but you really want to change the scenery, change what you're doing, and avoid forcing the sleep process to happen. We cannot snap our fingers and force sleep to return. We have to put ourselves in the right environment and condition to return to sleep. And so for many, this might be going to a sleep spot or an area in the house where you've got a blanket and a book where you can do something quiet so that you can have the sleepiness return over time, and to recognize that sleepiness return, and then try to reinitiate the sleep process.
Thank you. Thank you for that, Dr. Conroy. The next question I'm going to push to you, Dr. Goldstein. What is a circadian rhythm, and what does it mean for my sleep quality or quantity?
Well, a circadian rhythm is the best rhythm. So it's one of, I think, the most interesting topics in biology. So what a circadian rhythm is essentially our internal timing system, and our central circadian rhythm that coordinates some of our subordinate circadian rhythms in the peripheral organs and cells of the body. That central clock is actually located in a physical location in our brain, and it's set genetically. And what the circadian rhythm does is it allows organisms that live on Earth to respond appropriately to light-dark changes. So it cycles roughly every 24 hours, and it's not a reaction to light directly. It's not a reaction to time, but it's inherently built in us. So we're prepared to optimally respond based on the light-dark cycle. And for the purposes of sleep, the central circadian timing system times sleep and wake, so that wake is most likely to occur during the daytime and sleep is most likely to occur during the nighttime. So if you think about, for example, people who are equally sleep deprived and you assess them at either 10 a.m. or 3 in the morning, they're going to be a lot sleepier at 3 a.m., even in the context of the same amount of sleepiness. Now, the interesting thing about our circadian rhythm, even though it's completely inherent to us, we can move it around. It's plastic. And the way we move the circadian timing system around is with light. And the way we are equipped is that morning light and daytime light, so natural light, is what keeps our circadian clock aligned to the 24-hour day. But what do we have now? We have artificial light. Not only do we have artificial light, we have artificial light that you can take with you without even hitting a switch. You can bring a little miniature sun into your bed at night. So as you can imagine, the circadian rhythm and its modulation by light have become really, really important areas that we can target to help improve people's sleep.
Thank you for that. That's absolutely fascinating. The next question we have, how much sleep do I need? And how about my kids? How much sleep do they need?
Well, no one can know absolutely how much sleep you need personally. So on an individual level, probably the closest you can get to figuring this out is to take about 2 weeks off. Don't set an alarm. Use the first week to kind of correct potentially any prolonged sleep deprivation that you had. And then when you start waking up naturally, after that time, that'll kind of show you how much sleep you need. But on average, most adults typically need somewhere between 7 to 9 hours of sleep. Human biology is not dichotomous, it's in a bell-shaped curve, right? So there'll be people on the lesser end of that and people on the greater end of that. Most people like to believe they're on the lesser end of that, but it's probably not the case. And what happens when we start thinking we only need 6-7 hours of sleep and then we're acclimated to the sleep loss, which we know doesn't happen, that, it's probably that they do indeed need more and they no longer recognize their deficit, which we know happens in sleepy people. Childhood sleep depends on the age. So toddlers need a lot of sleep, about 11 to 14 hours. Preschoolers, about 10 to 13. School age kids like mine, 9 to 11 hours of sleep. And you can imagine I am like an officer when it starts getting close to bedtime in my household. And then teenagers, 8 to 10. And the interesting thing about sleep need in teenagers and that circadian rhythm that we just talked about is part of the normal process of going through puberty is a delay or a late shift of the internal clock. And that's why your teenager might prefer later bedtimes and wake up times. It's not that they're not listening to you when you wake them up for school. It's that it's biologically still the nighttime for them.
Thank you. I think that's a crucial point. Dr. Goldstein, should I use a wearable like my Fitbit or Apple Watch to track and score my sleep? And if so, what should I be paying attention to?
Gotcha. So another incredibly interesting development that's taken place in sleep over the last, 10 years or so, beginning with fitness trackers worn on the wrists and then moving to smartwatches and even rings. These wearable devices can be purchased by consumers, so we see them all over the place, and people have a lot of questions about what they are telling them about their sleep, and I'll just show you. So this is a smartwatch, and this does not track sleep. Smartwatches, so the little light on the bottom here, I don't know if I can get, it's off right now. That little light is something called optical photoplasmography. And what that light does is it detects the blood volume in the small vessels on the back of your wrist, and it determines pulse or heart rate and different ways to mathematically transform that heart rate. The other thing that this has inside of it is an accelerometer. And so that measures motion in 3 different directions. So it's heart rate and motion activity. It's not how we traditionally define sleep, which is by brain waves. But that being said, the heart rate and motion activity is then modeled by mathematical algorithms. We don't know a whole lot about them because, companies have trade secrets, and that's going to tell you if you're awake, you're asleep, what stage of sleep you're in, and you oftentimes will get these scores like sleep quality, sleep depth. So I actually find these devices very interesting because where do you get 99.9% of your sleep? It's not in our sleep disorder center in the sleep lab. It's at your house. So I think they have the potential to tell us a lot. But when you think about it, it does make sense that we move less when we're asleep than when we're awake. So the motion component of these devices is likely to tell us when somebody's laying still and potentially sleeping. And then the heart rate changes, which occur during both sleep and in between sleep stages. So your non-REM sleep that most people have heard of, and then your stage REM sleep, where your rapid eye movement sleep, where most of your dreaming takes place. So those sleep stages are defined based on brainwave activity. So I'm very hesitant regarding the accuracy of these devices to stage sleep, but I do think they can give us a good idea of when somebody is laying in bed. And if you're a good sleeper, most of that time will be spent asleep. So that can tell me a lot about your sleep patterns. But the problem is people often are interested in the sleep tracking capabilities of these devices when they're having bad sleep. And that's what we don't know as much about the accuracy of. Nonetheless, what I tell my patients to look for in these, because I don't want to throw the baby out with the bathwater, I think they have a lot of relevant information and they are the future of our field if we can improve accuracy and transparency, is to look for trends, right? If you feel great, feel like you're sleeping great, and your device tells you that you got up in the middle of the night and climbed 3 sets of stairs, probably wrong. If you're noticing that some nights you sleep great and feel great, and on those nights you see certain patterns as compared to other nights when you feel that you're waking up a lot, you don't feel so great the next day, and you see patterns showing that the sleep was restless, there were a lot of awakenings, maybe that's correct. We have rarely, but sometimes seen individuals that didn't have any other symptoms, that disturbances in their sleep based on their device did end up indicating a sleep disorder, but it's really hard to know. So if you're using these devices to give you ideas about trends, if you're using them to make changes in your behavior, like, hey, I realize when I spend 8 hours in bed trying to sleep as opposed to 6 hours, I'm feeling better the next day, keep going with your device. If your device is making you anxious, you no longer trust how you feel, and you only trust this quantified measure, which is, like I just said, of unknown scientific validity, then and there's actually a name for this. We call it orthosomnia, when people become overly focused on the sleep metrics provided by their consumer wearable. If you're experiencing that kind of tension and stress, ditch it for a while. We slept a long time before these devices were invented. We do not need them. So use them for good. You bought them. The manufacturer is selling them to you. These should be used to help you and not harm you. And I can't wait to see where they go in the future, though.
Thank you. That's fantastic advice there. The next question is for you, Dr. Conroy. And this is a pretty big one. What should my bedtime routine look like? Alcohol, caffeine, exercise, light exposure? How should I be paying attention to those things?
This is a great question and one that comes up so often. And I'm going to continue with some of the themes that we've already started so far today. And I'll start with the circadian conversation with respect to light exposure. Before I provide some advice, though, I always like to remind people that sleep is so fascinating because it's both biology and psychology and other things. There's so many things that go into the process of falling asleep. So starting with the biology in the circadian cycle. So when we are preparing for bed, we recommend that the lights be dimmed. Why is that? We want our natural production of melatonin to come on board. Melatonin is not just found in the pharmacy, it's found in our brains. It's a naturally occurring hormone in the brain. And by lowering the lights an hour or so before bedtime, you're allowing that natural melatonin rhythm to come on board. You also want to be free of caffeine or caffeinated products. So always check the labels of what you're consuming. If you like to have tea after dinner or coffee, just make sure that it's herbal tea or decaffeinated, but even decaffeinated products sometimes have caffeine. Exercise is very helpful for sleep. Many studies support that, but you don't want to exercise or be going up and down stairs or elevating the core body temperature right before bedtime. So avoiding exercise, avoiding stimulants, avoiding a large meal right before bedtime. And anything else, any other substances that could get in the way of sleep, you want to kind of avoid those. What you want to include, perhaps, reading is a good one. Even TV to some extent. I know everyone's sort of stuck to their TV and their shows. We do want to be careful of light, but sometimes we have our certain ways of liking to wind down. So find what is helpful for you to wind down and engage in that disengagement really from the day.
I think that's fascinating. For me, it's always been books ever since I was a little kid. But the ultimate irony is, I read half a page and I'm out. So I don't get that much reading in because it works so perfectly for me. But thank you for that. Thank you a lot. The next question I have: how should people who work night shift or other non-regular shifts approach their sleep? And I'll push that to you first, Dr. Conroy.
When we work with people with, they're called circadian rhythm sleep disorders. So this circadian timing can be affected by what we choose to do. So working night shifts or working rotating shifts can influence how we feel during our waking hours and how we sleep really during the day or night. There are interventions that we deliver in our clinic that really seek to, as best we can, align the sleep-wake rhythms to as closely as we can. So what that would look like would be something like if I wanted to work night shifts during the work week and sleep at a normal time on the weekends, we would try to come up with a pattern that's not so dramatically different on the weekends to include some consistency. Consistency is key. Anyone who's ever worked with me, and perhaps there's some patients listening today, routine, regularity, consistency, the brain loves that. And so we would discuss how to incorporate that in one's life. It is very challenging, especially if you have obligations and family who you don't get to see. And so striking the right balance for consistency in every day with your sleep-wake schedule.
I see you nodding, Dr. Goldstein. Anything to add?
Yeah, so as Dr. Conroy noted, circadian rhythm disorders, they can kind of be split roughly into two. It's an oversimplification, but problems with your internal clock. So your body wants you to sleep at a different time than you need to sleep. So for example, people with a condition called delayed sleep wake phase disorder, their internal timing system promotes sleep much later. So if you're trying to get up at 6 a.m. for work, but your body doesn't want to go to bed until 2 a.m., you're going to be chronically sleep deprived and sleepy. But then the other class of sleep disorder, circadian rhythm sleep wake disorders, is if the circadian clock is thought to be normal, but we're putting an abnormal required schedule on it. So like we talked about before, the circadian timing system, when it's normally entrained, it promotes wakefulness during the daytime and sleep at night. And night shift is not an uncommon phenomenon. And in that situation, you are working at night and your allotted sleep period is during the day. So many people are very sleepy during the shift from a circadian standpoint. And then when they try and sleep during the day, because their internal timing system is promoting awakeness, alertness, it's really hard to stay asleep. So you might fall asleep because you've been up the whole night working, so you can fall asleep easily, but then you can't maintain sleep. And so what the ultimate goals of treatment in that scenario is we try and move the internal clock to match the external schedule. And the easiest way to do that is if you make somebody completely nocturnal and they stay on a consistent nocturnal schedule. So like Dr. Conroy said, consistency and regularity. The problem is we rarely see people that are willing to do that. And so like she discussed, there's concepts called the compromise position and anchor sleep. And what you're trying to do is you're trying to find a shared period of sleep that will work when you're working the night shifts as well as your days off. So for some people, what works for them is after the last night shift, they take a long nap, they wake up, have some time with their family while it's still relatively daytime or afternoon, evening, and then they become a complete night owl for the rest of the time off, for the rest of the days off. And that helps kind of have this shared period, or what we call anchor sleep, so that you're not shifting completely and there's no shared period. But it can become a very complicated problem because shifts often rotate. We see shifts rotating in a direction that it's nearly impossible for the internal clock to align to. So it's a difficult problem, and we really have to work not only with the schedule, but also somebody's internal circadian preference. So for example, there's some night owls that might like these later shifts, and we don't have to do much. But together we can typically come to a solution with our patients that involves light exposure, light avoidance, and sleep-wake timing.
Thank you for that. And you touched on just now circadian rhythms again. Could you answer this question? Why is morning light so important?
Sure. So the way we talked about the circadian clock is plastic. So light moves your clock around. But the way your light moves the clock around is dependent on when the light is received. And we don't have a good way to measure people's circadian phase. So we do it based on their natural sleep times. That means not when you want to sleep, but when you do sleep. So a child on summer vacation or an adult on vacation. And we know that your body's melatonin secretion begins roughly 2 hours before your natural sleep onset. And then you hit your absolute minimal alertness about 2 to 3 hours before your natural sleep offset or awakening. And that's when we time light based on that. And we know that light at the very end of the natural sleep period, so the early morning, and also the few hours after the natural sleep period and during the daytime, that moves your internal clock earlier. And the reason that we need that is because your internal clock, it cycles on approximately 24 hours, but most people it's a bit longer. In most people, it's 24.2 hours. So if you didn't have that morning light, which brings your clock earlier each day, so it aligns to the 24-hour day, what would essentially happen is that you'd fall asleep and wake up later each day. And that's why morning and daytime light is so important every single day to align that longer than 24-hour clock to that external 24-hour day. Why do we have this strange system? This probably goes back to before electricity was developed, and the length of the days told us what season it was, when we needed to reproduce, things like that. Day length used to be very important. And so this system is how we determined what day length was. Now, what we're not equipped for is light at night. And light during the last 2 hours before your body's melatonin secretion and continuing through bedtime and those first few hours of sleep, that moves your clock the other direction. So later as opposed to earlier. And that can be a big problem. And I see that all the time in my clinic, where, especially during the pandemic, where structures became a little less rigid, that people who were staying up playing video games on social media really had a phase delay or became more of a night owl on their schedule.
That's fascinating. And as a follow-up, we have a viewer question. Does a circadian rhythm disorder begin in childhood? And if so, how is it treated?
So it can. We see these arise at different times, and that really was well described by what Dr. Conroy said is there's an interaction between biology and behavior with sleep. But the most common thing we see is because we see that phase delay, that becoming a night owl in adolescence. That's often when we see delayed sleep wake phase disorder take place, is in teens or young adults, but oftentimes persisting into adulthood. And when it becomes apparent is when people try and take a job out of college with a conventional schedule and they just can't align. And our treatments for these disorders, and they're different based on the different disorder, hinge kind of in the opposite direction of what we talk to shift work. So when you're treating a circadian rhythm disorder that's based on kind of an internal abnormality of the clock, the patient's natural biological rhythm, doesn't want to sleep and wake in association with conventional times, then we're trying to move that natural rhythm with light exposure, light avoidance, low doses of melatonin, so that the patient can sleep and wake when most others do.
Thank you. Thank you for that, Dr. Goldstein. Dr. Conroy, I'm going to pass this next question on to you. The question asks, should I buy a light therapy lamp, blue light glasses, a white noise machine, a weighted blanket, an eye mask? Could you speak on how effective those are?
Sure. So the short answer to my response is going to be whatever is going to help you. I never like anyone to incur any expenses, any more expenses than they're already paying to, in the old days, arrive at the clinic or paying their copay. But some of these tools, I guess I'll say, can be quite helpful for the time period during a treatment duration. So if I'm working with a patient, I might discuss with them possibilities of getting something like a light box, or there are many other sort of gadgets out there like retimer glasses that shine light in the eyes, so that we can work with these tools as an intervention. So if I assign light therapy, they're going to have their light box. I'm going to tell them what time to use it. In cases with external environmental noises or noisy bed partners, oftentimes things like earplugs or white noise can be quite helpful. Weighted blankets, there was a study not too long ago done on those and showed pretty good results. And so I would say, yeah, if you can do it and you would think it's helpful, then they may be something to invest in.
Thank you. Thank you for that. And my next question for you, Dr. Conroy, do CBD or other forms of marijuana work for sleep?
The research in this area is still in its infancy. And I think that's the point that I would like to leave people with. But to date, CBD and cannabis have been used quite a bit for sleep and other things, including pain. And some studies show indeed that these products, like cannabis, can reduce the time it takes to fall asleep, and in some cases increase the level of deep sleep. The problem that we sometimes see, however, is with more frequent use, whether that's a daily user, someone who is using these products multiple times a day. And so if you're using more frequently or using in high doses, the insomnia or the sleep can be affected in a negative way. And also there are several studies that show in chronic cannabis users who abruptly stop using cannabis for sleep can experience a rebound insomnia, both subjectively as they describe their sleep and objectively when we study them in the sleep lab.
Thank you for that. I'll pass the next question to you first, Dr. Goldstein. Are Ambien or other sleep aids like melatonin safe? Should I be worried about perhaps getting addicted?
So let's start with the Ambien question, because I would say that Ambien and melatonin are just vastly different. So Ambien is a prescribed sleep aid. And if you talk to people, anecdotally, they'll say, it really worked for me. And now I don't think I can sleep without it. But what we actually know is when we monitor people's sleep, these prescribed sleep aids don't give you any longer than 45 minutes or so of actual sleep. And the problem is the side effects many times could outweigh the benefits. So there's next day tiredness, there are driving impairments, imbalance, problems with thinking and memory. So we really want to be judicious of our use and ideally only use these medications for the short term. And just thinking more broadly is that, no one has an Ambien deficiency. There's not typically melatonin deficiencies, Tylenol PM deficiencies. Your body is biologically equipped to sleep. And even though taking a pill is a very passive, easy activity, because we're biologically equipped to sleep, behavioral changes can make such a massive difference. and they really don't have many side effects. So, in most cases, I really think that behavioral change is the way to go. Um, but sometimes we do have to use a short course of prescribed medication in some individuals, and we never want to let insomnia go untreated, particularly in the context if it's complicating a mental health disorder. We want to make sure that it remains treated. But I find that many people, just with simple behavioral changes, can really, really improve their sleep. Melatonin's a bit different. People consider melatonin a sleep aid. And the way we like to use melatonin, oftentimes in the sleep field, is a chronotherapeutic. So we use it at really, really low doses, 0.5 milligram or less. And we're using it to move your own internal timing system to promote sleep, as opposed to using the melatonin for its sedating properties at higher doses.
Thank you for answering that two-part question. The next one that I have up, this question is with regards to naps. Are naps a good idea? And if so, what's the best way to go about it? Should I perhaps take a nap during my lunch hour if I'm working at home?
The key to napping definitely can mitigate some of the performance decrements we see due to chronic sleep loss or even acute, more severe sleep loss. And the best way to nap is if you can nap for a short duration. So 30 minutes or less is what we see that improves performance without causing something called sleep inertia, which is this grogginess upon transitioning out of sleep into wakefulness. And I find the best time to take it is after lunchtime, because you've been up a full half day, you have a bit of a sedating effect from food, you're approaching a time in your body's schedule called the circadian dip, and it's not too close to bedtime. So that's how I would optimally use naps for somebody that finds they're getting a little tired during the day. But you also want to make sure, if you need a nap, please take a look at your nighttime sleep too. Is there something wrong with your nighttime sleep? You're not allowing enough time for it, or you have an underlying sleep disorder that could be causing your need to take a nap because it's making you sleepy.
Fantastic. I see you nodding, Dr. Conroy. Anything to add from your end?
Yes, just to highlight, always looking at your nighttime sleep, because I get asked this question so often in people who suffer from insomnia because they're not sleeping well at night, so they're compensating the next day by taking a nap. And in that case specifically, I would actually tell them to avoid naps if safety permits. Certainly, if you're a truck driver, or you're driving, you take naps for safety reasons. But it is a core component of intervention for insomnia to avoid any kind of daytime sleep, because it just takes away from the quality of sleep that you get at nighttime. But if you sleep okay, you're a good sleeper, and you're just feeling a little sleepy the next day, by all means, brief naps, appropriately timed, are recommended.
Thank you for that. Let's get more in depth with diagnosis now and treatment of sleep disorders too. Dr. Goldstein, what sleep disorders do you see most often, and how do you diagnose them? One viewer asks if you can describe how a sleep study works.
Oh, great. That's a great question. So, the sleep disorder that we see most commonly is obstructive sleep apnea. And what obstructive sleep apnea is repetitive obstruction of the upper airway, so usually behind the tongue or behind the roof of the mouth during sleep. And this can occur hundreds of times during sleep. And what happens when the airway obstructs is that the lungs don't fill completely with air, the oxygen levels in the body can drop, and so the brain wakes up to resume that airflow during sleep. Many of these awakenings will be less than 15 seconds, so people won't even perceive them, but they feel sleepy the next day. And the other problem with obstructive sleep apnea is we know it has a lot of short and long-term consequences. So in the short term, that sleepiness can increase your risk for accidents, errors, including motor vehicle collisions. And then in the long run, obstructive sleep apnea increases your risk for high blood pressure, different types of heart disease and heart arrhythmias, diabetes, stroke, and even cognitive and memory problems like dementia down the road, which is an emerging field right now. The way we diagnose obstructive sleep apnea is through a sleep study, and that might occur in the laboratory, and I'll talk about that one first. So that's our full sleep study. So you'll come in and you bring what you would bring to a hotel: pajamas, toothbrush, etc. And the sleep lab tends to have the rest, bedding, towels, whatever you need, and you get all hooked up. So EEG leads are put on your head with kind of a glue-like material, and those EEG leads measure your brain waves, and they tell me if you're awake, if you're asleep, and what stage of sleep you're in: non-REM light, non-REM deep, or stage REM sleep. And then we monitor some muscles around your eyes and your chin and your legs, and those also help me determine what stage of sleep you're in, as well as if you have any abnormal behaviors or movement in your sleep. The breathing, that airflow, to determine if there's cessation or blockage of airflow, is through two little prongs in the nose, and then also a measurement in front of the mouth. And then we measure how hard your body is trying to breathe around the chest and abdomen, because the key feature of obstructive sleep apnea is that your body is working to breathe, but that upper airway is closed or obstructed, as opposed to a less common disorder called central sleep apnea, where your body is just taking pauses in your breathing. We also monitor your oxygen levels on your finger and EKG to measure your heart rate during sleep. And despite being all hooked up, I rarely see people who are up the whole night. It may not be the best night of sleep that you get your whole life, but it is enough for us to determine a lot of information about your breathing at night and whether or not you have obstructive sleep apnea. For certain individuals who we're pretty convinced have very significant obstructive sleep apnea, and we think we can detect it even without monitoring all the different parameters. We can do a sleep study at home, and those typically entail just monitoring the breathing at the nose, one respiratory effort measure, an oximeter on your finger, and a measurement of heart rate. And we don't have all that EEG hookup. You're not laying in a bed in the hospital on camera. You're sleeping in the comfort of your own home. And then your providers will interpret the signals that come from this monitoring, and that's what tells us if you have obstructive sleep apnea or not. So we do the diagnostic testing. We can't make a decision only on what people tell us. We like to confirm that and also quantify the severity, whether it's a mild, moderate, or severe case. And that is then relayed to the patient, and together we discuss what options for treatment you have.
Thank you. Thank you for that overview there. We have a viewer question here. Any tips for someone who experiences sleep problems related to bladder problems?
So, it's hard to know without knowing more medical information, which we're not going to do here. But one thing I will say is that obstructive sleep apnea often presents with having to wake up very frequently to use the bathroom, just due to physiological changes that occur in the context of sleep apnea. And because you oftentimes don't know that your airway is obstructed, but you do know if you wake up and have to use the bathroom, the sleep disturbance gets attributed to the bladder as opposed to the airway. And so oftentimes we're going to look for signs or symptoms of sleep apnea in somebody that's experiencing frequent urination at night.
Thank you. Thank you for that. Let's move on to this next question for you, Dr. Conroy. How does sleep relate to your mental health or your mood and depression? What's the best way to make it a positive relationship?
The relationship between mental health and sleep is very much bidirectional. And by bidirectional, I mean that sleep can sometimes be an indicator, or sleep disturbance can be an indicator of other mental health issues going on. And also the other way is if I start developing insomnia, that can create irritability and anxiety and depression the next day, and you get caught in this vicious loop. So in the sense of how can I make this a more positive experience, much of the work that one would do if you suffer from chronic insomnia and you meet with someone like myself, a sleep psychologist, would be to better understand the types of thoughts that you are having. And there is a process that we call cognitive restructuring, or changing the thoughts as they relate to perhaps sleep, and working and rehearsing those. Other people, which this isn't a standard part of the intervention for insomnia, but you may have heard about things like gratitude journals or writing things down about your day prior to going to bed. I will sometimes recommend that people do something called constructive worry, where you pick a time well before bedtime to actually focus on worrying. You take 15 minutes and you jot down all the things that might be keeping you up that night, and you put it down on a piece of paper. Why do we ask that? Well, because you don't want to take your problems to bed with you as much as possible. So you're putting it on paper, you can see it there. And in some cases, I'll have people bring this into the bedroom with them, put it on the bedside table, so that when they wake up at 3 in the morning, they could say, you know what, I've dealt with these things at my problem solving best or better, and there's nothing more I can do about it at this time. But I would definitely encourage people to express this and discuss any kind of mental health issues with their doctors, because there are certain assessments and tests and lots of evidence-based treatments out there to improve mental health.
Thank you. And as a follow-up to that question, we have another one that asks, could you speak about the link between trauma, like PTSD, and persistent sleep disruption? Are there therapies, apart from medication, that help people get relief from PTSD-related nightmares?
Trauma is a very common contributor to insomnia down the road. And while I won't go into the specifics of it, there is something called hyperarousal that can sometimes happen as a consequence of trauma that can lead to sleep disturbance, as well as many, many other symptoms. There are treatment interventions for trauma specifically that they could discuss with a general psychologist. And we often recommend that someone undergo these types of treatments, like they're called cognitive processing, to explore and address the trauma. The question about nightmares, however, when someone has undergone, or in some cases, people have undergone treatment for their trauma, but they're still having recurring nightmares. There are evidence-based practices for nightmare intervention. The one that we practice in our clinic is called ERRT, so it stands for exposure, relaxation, rescripting therapy. And long story short, it is working with the patient to understand what the dream is, what are the themes, and we work on rescripting that dream and pairing that with relaxation in a safe setting in the office or in the Zoom.
Thank you. Thank you very much for that, Dr. Conroy. The next question that we have, and I'll push this one to you, Dr. Conroy. What is CBT for insomnia, and how does it work?
CBT stands for Cognitive Behavioral Therapy for Insomnia. Well, we add the for insomnia. CBT is a very commonly used approach for many, many disorders, namely anxiety, depression, and it is a specific protocol for insomnia. So CBTI, you might have heard about. And this is a series of treatment sessions geared towards addressing the chronic insomnia. And it is the behavior may include sleep scheduling, it may include tracking, whether that's in apps or writing good old-fashioned paper and pencil. And it also involves addressing the thoughts about sleep or worries that can perpetuate the insomnia. And so one of the things I often tell my patients is that we can't go back in time and change what happened that triggered your insomnia, whatever that is. But over time, we develop changes in our habits, our behaviors, our thoughts. We start to worry about sleep. And CBTI is specifically geared towards those perpetuating factors, because then it can just interrupt this vicious cycle of insomnia.
Thank you. Thank you very much for that. Let's zip on to our next question. Why do I have a hard time settling my legs to fall asleep, and what can I do about it? Dr. Goldstein?
Yeah, so that sounds like a condition that we see called restless leg syndrome. And in restless leg syndrome, individuals have an urge to move their legs when they're at rest, and it occurs primarily in the evening time, and extends to before bed. And it can be very uncomfortable. It can interfere with falling asleep, can also cause a lot of issues with quality of life. And we think that the mechanism underlying restless leg syndrome has to do with dopamine transmission down the spinal cord, and also central nervous system iron storage. And so we often measure iron in individuals, and this is a great kind of thing in medicine. We love when we can identify and treat something and improve somebody's life by just supplementing their diet. And so in individuals who have iron that's even in the relatively normal ranges, but at the low end, we can give them an iron supplement, and that will oftentimes improve their restless legs. Unfortunately, this is not always the case. And individuals who have a lot of problems due to the restless legs, it's interfering with their sleep or making them very uncomfortable, and it's not resolved with just getting up and walking around, we have to use medication sometimes in that context. And that is something that you can discuss with your healthcare provider.
Thank you so much for that. We've answered quite a few questions. I think we can squeeze in one more. Does everyone with obstructive sleep apnea have to use a CPAP mask? People have a hard time being compliant with them. How can you get used to them so they can work?
So that's like 4 questions, and I think decades of research. But this is very, very important. So we treat obstructive sleep apnea due to those downstream health consequences. But importantly, we treat obstructive sleep apnea to improve people's function and quality of life. And the reason that we often go to CPAP first is not because we're trying to make people nuts, but CPAP, regardless of why you have obstructive sleep apnea, whether it's related to your weight or your anatomy of your airway, or maybe your obstructive sleep apnea is just due to your brain's control of your breathing. We don't know the exact cause in the exact individual. That's something that in the future, precision health might help us with. But what CPAP does is, regardless of the cause, CPAP holds the airway open. And what CPAP is, for those of you that don't know, it's a machine. They're now about like this, a little bit bigger than a laptop, and it generates positive airway pressure. That's where the PAP comes from. Positive airway pressure. That pressure goes through a tube, and then the tube is connected to a mask, and the mask either goes into the nose, over the nose, and over the nose and mouth, as made famous by the ad in the Airplane magazine with the guy like this. So CPAP is great, again, because we said it treats obstructive sleep apnea very well, regardless of cause, but also besides the inconvenience and kind of getting used to it, which for some people is very easy and other people is very hard, there's really not any adverse events with CPAP as opposed to other things that we can do for treatment. So different ways that you can get used to CPAP is making sure that your pressure is comfortable, that the masks, there's hundreds of masks available, and there's been a lot of innovation in masks the last few years. Instead of just the tubing coming off this direction, tubing comes off the vertex of the head now, which allows for a lot more freedom of movement. So making sure those things are correct, but also something called CPAP desensitization, which I'll let Dr. Conroy talk about a bit more, is a great way to help you get used to your CPAP mask. And then other options for therapy, depending on the severity and the situation, are typically surgical or dental. But I would love to hear Dr. Conroy's thoughts on CPAP desensitization techniques that people can use at home, because I find these are very helpful for our patients.
In the last 60 seconds, I realize. So in short, it is a process where you sit with the machine for smaller, shorter periods of time while awake, to get you comfortable with the machine while awake, so that you're more comfortable while sleeping. And it is extended over multiple days, if not weeks, to avoid the pressure that people feel, not the positive airway pressure, but the pressure that sometimes the patients are under to wear their mask due to insurance reasons or others.
Well, thank you both for answering this wide variety of questions. I really appreciate your time and your expertise. You can also, if you're a viewer and you want to follow up on any of this, visit uofmhealth.org/better-sleep, and that link is in the chat for our live streamers. It's in our Facebook chat for our live streamers. So one more time for everybody else, that's uofmhealth.org/better-sleep, and you will find that in our Facebook chat. Again, one more time, Dr. Conroy, Dr. Goldstein, thank you so much for your time. And to all our viewers as well, have a great afternoon. Thank you.
Thank you.